evening and welcome to Milford Regional Medical Center. I'm Donna Boynton. I'm the Public Relations and Community Benefits Coordinator here at Milford. Tonight we are joined by Dr. Brian Clark. Dr. Clark is a graduate of the University of Vermont College of Medicine, and he completed an internship and residency in obstetrics and gynecology and a fellowship in reproductive endocrinology and infertility at Fletcher Allen Healthcare Association, associated with the University of Vermont College of Medicine. Dr. Clark opened New England Reproductive Medicine and Surgery in Millbury in 2013, and he is one of the area's premier specialists in reproductive endocrinology and infertility. Tonight's talk is about treatment options available to start or expand your family. So, Dr. Clark, all yours.
Thank you, Donna. So what do you have to do to sort of go on to become parents, add to family, that sort of thing? And so there's a lot of different considerations here, and we'll walk through that sort of process, and hopefully it'll enlighten things. But you can ask any questions you want, either now or afterwards, whichever. Okay. That's sort of the goal. Maybe not all three of them at once, but you know, the goal is to get to a baby and expand families. This is me, a lot of credentials, but as Donna said, I'm a reproductive endocrinologist. That means I've done special training in reproductive endocrine and infertility area of medicine, and my original training was in OBGYN. And I still do a lot of things within OBGYN, but I focus on the reproductive endocrine part in particular. This is where I work. This is the practice that I started in Millbury about 5 years ago, a little over that now. I used to work at University of Massachusetts at the Worcester campus. There I was the director for their reproductive endocrine division for about 8 years. This is how you get a hold of us. I've got all this information on cards if you wanted to have it, so you don't have to write it down. You can just take a card later. So it's there, and it'll show up at the end as well. So a lot of people have trouble getting pregnant when they're trying to get pregnant, or expand their family if you choose to use that terminology instead of specifically getting pregnant. Women can do that without a couple being involved because they have the parts to do that, so they can. And there are ways to do that. And couples are often trying to do this. And this is one of those things that I think our society doesn't really deal with very well, because a lot of people have this sort of stuff going on when this doesn't work. And they don't really necessarily talk to their family and friends about it because people around you are getting pregnant all the time. And women who have trouble getting pregnant, couples who have trouble getting pregnant, don't have a good sense of who to go to and how to talk to people. There are resources. There are people who can help, but it's often something that couples or individuals deal with in silence and by themselves, and they don't really need to do that. Families come in all sorts of shapes and sizes. 1 parent, 2 parents, 3 parents more. You can make it into a Dr. Seuss thing, I think, if you wanted to. Multiple genders, more than 1 kids, all that sort of thing. And really this is about how to help people expand their family, whatever that means for them. And so there's lots of different things that might apply, and they might not apply to you, and they might apply to you, and they might not apply to you, and they might apply to you, and it might apply to no one in the room, et cetera. So it's meant to be sort of all-inclusive. But there's some certain things that are sort of truthful in this game. You need sperm and egg to make a baby. There's a little asterisk next to that if you really want to get into some science stuff. You can read this part down here, but there's this thing called parthenogenesis that can actually occur without a sperm. So maybe men aren't necessary. Who knows, right? But so far that hasn't proven to actually, produce like babies. But you can actually get eggs to start growing by themselves. So it's a little weird. But aside from that weirdness, we're going to sort of stick with sperm and egg are needed, because that's sort of the way this game is played. Fertilization has to take place, and then embryos can start to grow. They have to be put into a uterus to survive, at least at this point in time. We aren't able to grow babies from conception to birth outside of a human uterus right now. But this is really going to be about how to get an embryo growing in a uterus and have it be then turning into a baby that can be born. This is an egg. And if you look carefully, there's a little sperm over here trying to do its thing. A little sperm over here too, trying to do its thing. And this is probably a sperm over here trying to do its thing. And so this egg is ready for the fertilization process. So hopefully we can make that happen. So with that background, let's get started. Let's start talking about what we can do about what we call infertility, which has a couple of definitions, which we're going to go into. So vast majority of couples with infertility, so we'll define that in a second, but the vast majority of these couples or these women will actually be able to conceive and have a child. So when I was in my original job out of training, I had to collect data for a case list for my board certification process. That made me collect literally all the data for all the patients that I saw for an entire year, which was kind of a pain to do. But that meant that I had to literally look at all the outcomes for all those patients. And I got to see, by doing that, it was actually useful for this, that about 95% of the couples that I saw for infertility actually conceived at some point. Not necessarily at the first time that they tried to do something, but if they kept working at it, the vast majority of these couples conceived. And so if someone's trying to have a baby and trying to work at this, if they will work with what is available to work with, they're probably going to be successful. It's not just about having sex. That's the usual way, the most common way, the cheapest way. So it's got some benefits, but it's not the only way. And like we already said, we're really just trying to get sperm and egg together, and that's what fertility care is really trying to do. So how do we do that? Planning is important. Right? So this gets us to a sort of a set of questions about what do we do about trying to get pregnant, but what do we do about preparing for pregnancy as well? So this is sort of a reminder to say that whether we like it or not, whether it's fair or not, the woman's age is the single most important factor involved. Women that are older, women that are older are just not that likely to conceive on their own, and maybe not that likely to conceive ever, depending on their personal data that can be gathered. So you can sort of see how I break this down. This is not rocket science. This is basic biology. Unfortunately for women, maybe fortunately, I don't know, it's just the way women are, eggs are created when you're in utero. When you're being built in your mom, that's when you create your eggs. And you don't create more later. So as you go through your reproductive years, you use the eggs that you've got to try to have cycles, and at the end of the line, you literally run out of eggs. So when we get to this point down here where we're having trouble getting pregnant, it's because biology is catching up with us. And that's why there's really a time clock here. Men don't have the same time clock. There's a little bit of a time clock, but not nearly the same thing. And so this is the single most important issue. So if I could sort of spread the word out there, I don't want women to show up in my office at 48 years of age saying, "Can you get me pregnant?" Because I really don't have very many tools at that point in time to really help her. I might be able to, but I'd really have her shown up rather have her shown up in my office when she's 30, because then I have a much better assortment of tools that are much more likely to work. So age is an important thing. There's lots of reasons why women aren't having babies at, say, 18 years of age. 100 years ago, that's when women had babies, right? Or 200 years ago. But now, there's all these considerations, and there's the same considerations for their partner, and trying to create an environment where they can put a family together. It's not just, when's the best time to have a baby? Because the best time to have a baby physically is going to be a younger age. But when you look at all these things, if you're trying to build your career and get your education and do all those things, you have to do that while you're worrying about trying to build a family. And those two things don't always go together so well. So I don't pretend to say that it's just as easy as saying, show up on my doorstep by the time you're 30 and don't come if you're after 30. That would be sort of silly to say, because that's just not the realistic world of what women have to deal with, nor couples. What do I do to get ready? Well, you have to get ready in all sorts of ways, right? Get ready because you have a partner with whom you're going to get ready, or you don't have a partner with whom you're going to get ready, whichever way it's going to be. You talk to your support structures and the people in your family and in your environment, so you know who's going to be able to help you. Because guess what? You're going to need help. Raising a kid is not a one-person gig. It's not a two-person gig. It's a village thing, right? You have to include people around you, because there are going to be times when you need it. There are going to be times when you have to go over there, and you have to go over there, and you can't clone yourself and be in two places at once. And so you have to rely on the people around you. You have to think about those things. What about the financial considerations? I've heard a lot of different people talk about what it costs to raise a kid, but the number that's always stuck about in my head, I don't know whether it's really true, it's about $1 million per. Lifetime cost. Got to make $1 million for each kid. I don't know, that sounds like a lot of money, but it may not be that far off the truth, right? Obviously, medical issues have a big impact on what's going on as well. If you have medical issues, you need to think about those medical issues and how they might play into this. Obviously, you might have specific obstetric or gynecologic issues that might play a role in whether you can get pregnant, or whether you can stay pregnant, or whether you should get pregnant. And those are all considerations that you should undertake as you go. So what do you do prior to attempting pregnancy? You consider all those things we talked about. You go see your doctors or your providers, and you talk about things, oops, not used to your pointer. You talk about things like whether you need to worry about your weight, whether you need to worry about smoking cessation, what's your drug and alcohol use, what other medications are being used, what other medical problems do you have, what medical problems do you have that you don't know about yet. You know, all those kinds of assessments to make sure it's going to be reasonable and safe for you to try to be pregnant. What about your OB histories and what is going on there? Do you have any problems that you need to worry about, like fibroids or like endometriosis or like abnormal pap smears or anything else that might interfere with this process? Or what have you already had done that might interfere with this process? You should think about all those things. And then if you need to see other people, see whoever else you need to see. So if you have a cardiac problem, maybe you need to see someone about cardiac health before you try to get pregnant. All these things are important. In particular, I would highlight hypertension and diabetes. And that's because in pregnancy, both of those problems turn out to be potentially major problems. If you know people who've been pregnant, you probably know women who have had problems with diabetes in pregnancy or hypertension problems in pregnancy, preeclampsia, eclampsia, those kinds of things. They come up a lot. And they can be threatening. And when I say threatening, I mean threatening to your life. And certainly threatening to a baby's life. And so those are the two that I would emphasize. But all these things, any medical problems you have, you should be taking care of and stabilizing before you try to get pregnant, if you can. If you smoke, stop. Let me repeat that. If you smoke, stop. Smoking decreases your chance of being a parent. Male, female, doesn't matter. You decrease your chance by about 50%. So if you're a smoker, stop. If you use recreational drugs, stop. Some of those I'm not so sure that they're all that important in the real big scheme of things. So, you know, is marijuana really a bad thing to use? I don't know, but from a fertility point of view, it decreases your chance of success, especially if you're male. And it may get in the way of being able to conceive overall. And so if you use recreational drugs, I would say stop. You're trying to get pregnant, stop. I certainly don't want you getting arrested, and I certainly don't want you getting into physical trouble because you drove a car into a wall or something. Right? So none of those things help you get pregnant better and they might make it hard because you might be in jail. Review all the medications, consider prenatal vitamin or standard multivitamin. This part is not all that important as you're trying to get pregnant. Maybe important in some people in pregnancy, but this part, which is usually in the standard multivitamin, the folic acid or folate, they're the same thing. 400 micrograms of that daily for at least a couple weeks before you try to get pregnant is really a smart move. This will decrease certain birth defects significantly, and it's probably the one thing that is on this list that really becomes a mandate. So if you talk to any gynecologist or any obstetrician, they'd say, definitely take this before you're pregnant. Okay, you've prepped, you've talked about that. What are you going to do? How do you evaluate? How do you get ready? So if you have a male partner, then the first answer is you try a lot. And then you try a lot more. And you do this for about a year, because that's what we define as infertility. So the definition of infertility is 1 year of trying without success. If you don't have a partner, it's kind of hard to try. That makes it a little bit different. I happen to think that that means you have a fertility problem. So if you want to be pregnant and you don't have a partner with whom you're trying to get pregnant, then you have a fertility problem because you don't have sperm. So this is what we're trying to do. He's trying. He's trying. He's not there yet, but he's trying. Right? I love this picture. And these are the factors that we think about that impact fertility. This is the nuts and bolts. This is what we're trying to figure out when we're seeing patients and we're trying to figure out how we deal with fertility questions. These are the things that we're going to try to understand so we know how to treat them. And this is the way the reproductive endocrinology world talks about them. as these fertility factors. And they all have their impact. So let's go through them. So if you're having trouble conceiving, you've had the evaluation done, you need to investigate, or you're ready for the evaluation to be done, you need to investigate those factors that we just talked about. Once the investigation is done, then you can say, how do I treat those things? Whatever I found, how do I treat that? And that's sort of the whole plan. So this is the first of the factors in my mind, mainly because it's one of the most common. Two, it's a definite issue. If you can't ovulate, you can't have an egg that's ready to fertilize. If you don't have that, you cannot get pregnant. So this is an absolutely mandatory step. Right? And so what can cause these problems? Well, there's a host of medical problems that really revolve around problems with females that have a number of things, but the most common of them is PCOS, or polycystic ovary syndrome. And these problems lead to, many cases, endocrine dysfunction that can allow for poor fertilization or no fertilization. And so this is usually analyzed by doing lab tests. You do a bunch of hormone levels and say, this is what I think is going on. I found this problem. This is how I treat that problem and try to correct it. If you can correct the problem, you might be able to allow for ovulation to occur on its own. If you can't, then you might have to help. This is a typical picture of ovaries that look polycystic in nature. So all these little black things in the ovary are little follicles, and this is a classic PCOS appearance for ovaries. And this is the most common reason why women who don't ovulate regularly don't ovulate. So that could be a whole discussion by itself. We could have a whole hour discussion about this. We're not going to try to do that tonight, but if that applies to you, I'm happy to talk a little bit about that afterwards. Uterine factor. The uterus is obviously very important to this process. We need a uterus to grow a baby. We can't do it outside the uterus. So we have to have a uterus that can do the job. Most uteruses do. In fact, you can get women with very old uteruses pregnant. I'm not sure we want to, but the oldest I've ever heard of in the world was 70. So 70-year-old uterus responds. Okay, so this is the uterus is usually going to work. But some uteruses don't for various assortment of reasons. So you can have problems that are congenital. You can have abnormalities of the uterus that make it hard to get pregnant or stay pregnant. You can have hormonal problems such as the luteal phase defect where you don't get good growth of the endometrium that get it ready for implantation. You can have new things like fibroids and polyps that you acquire in your lifetime that can distort the uterus and its function. You can have no specific reason why you have implantation failure, but have implantation failure. That's not because there's no specific reason. It's because we're not smart enough to know the reason yet. So I'm sure they'll find reasons. We just don't know them yet. And then this stands for recurrent pregnancy loss. So it's really getting pregnant but not staying pregnant. And all those things can lead to not being able to go have a baby. And so you evaluate by a combination of lab analysis and ultrasound. And sometimes you have to do a little bit more, like the endometrial biopsy. And that gives you information about the endometrium, about the structure of the uterus, and about whether you think that can work. This is a picture of an abnormal uterus. This particular uterus has a little bit of an abnormal tube up here. We're not talking about tubal stuff yet, so we don't talk about that one for this picture. And this shape to the uterus is a standard, not standard, I guess, but this would be commonly called a bicornuate look. It's just, there's two sides to the uterus, and we don't know quite what the shape is by this test alone, but this kind of rabbit ear effect is not a normal uterus. This is a fairly normal looking tube over here. This is down towards the bottom of the reproductive tract. So the vagina would be down here, the cervix would be here, and this would be the body of the uterus. Tubal factor. This is now also one of the most common factors involved, and this is where the tubes themselves don't function normally. The most common problem here is going to be simply that the tubes are blocked. There's physical obstruction. They can't let the sperm and egg get together, and therefore you can't get pregnant. But there can also be some other things that lead to tubal motility issues. DES exposure would be one of those, and I don't think I'm ever going to see a woman who's trying to get pregnant at the right ages who has DES exposure anymore. It's so old that I think those women are now old enough that they're not trying to get pregnant anymore. But every time I say that in a public setting, I then, like the next week, I'll see someone who's got exposure to DES. So we'll see. So DES is a medication that was used a long time ago that we figured out as we used it that it actually had some problems with the reproductive tract in the offspring. for those women. And so most of tubal factor is going to be about anatomic problems that cause a blockage. It's typically some sort of imaging like the picture you just saw. That picture was called an HSG, which is this test over here, an X-ray dye test. Most of the time I do this test. I'm doing an ultrasound-based test version of that in my office. And that's how you get to know whether the tubes are okay or not. These are some pictures from surgeries. This is a normal-looking tube, normal-looking ovary, and this is a not normal-looking tube. And you can't really see the ovary on this picture for that. But that tube is dilated and blocked. And so that tube's not going to work. And, it's pretty obvious that tube's not working. It's not a normal tube. This tube looks pretty normal. That might work. Peritoneal factor. This means the cavity of the abdomen. And so this is one of those less well-defined fertility problems because there's too many things that it could be, and we link them up to some of the other factors if we are talking about that. So when you look at this as a problem, there's a host of things, but these are some of the same things we've put on some of the other slides already. And so is it really a tubal factor that's really going on, or is it really a peritoneal factor? Well, it's interesting because endometriosis itself can actually decrease your chance of getting pregnant. We don't know about cause and effect, so maybe I should say it's associated with. And you don't have to have tubal blockage to see that effect. So probably there are some things that just affect the peritoneum that can actually affect your ability to get pregnant. Right? This is the way you evaluate this, so this gets more difficult to figure out whether it's going on because you may have to actually do surgery to figure this out. And this is an example. This is endometriosis. This is the top of the uterus, so the front side of the uterus. This is all in the anterior pelvis. And all this blackish stuff is endometriosis. And you can see how there's scarring, sort of pulling everything in. And this is a fairly mild version of that scarring. Sometimes the scarring is massive. And if this is in the wrong place, like where the tubes are, down over here, then you may not be able to have tubes function because of this process. And this is just a process. It happens to about 5% of women. Male factor, another one of the most common things. I get this question a lot for whatever reason. I'm not sure I should pick on men specifically, but I might see patients and the male partner might say, well, we're going to do all that testing for her. Do I really need to do a test for me? And the answer is yes. So I'll give you some numbers. These numbers won't make sense, but think about what I'm about to say. So the male factor occurs in about 40% of couples. Ovulation problems occur in about 40% of couples. Tubal problems occur in about 40% of couples. And about 20% of couples have no problems that we can identify. So you can do the math there. What I just said makes no sense. What it does make sense is when you're thinking about it, is that means multiple things are at play in a lot of couples. And in some couples, nothing that we can find. So do you need to do this if you're a male cohort within this kind of thing? Absolutely. Because 40% of the time, I'm going to find something I need to worry about. So you can have low volume, low count, low motility, low morphology, viscosity problems. You can have infections like a low-grade prostatitis. All these things can be discovered, and they might play into this role. I would also implore men who are involved in a couple trying to get pregnant to talk to their infertility doctors before they do anything with their urology friends. No offense to my urology friends out there, but some of them try to treat men with like testosterone. Common thing now. You hear a lot of it on the radio waves and TV waves, low T kind of thing. Testosterone would be an outstanding male contraceptive. It might help with the sex thing, but it's not going to help with the sperm thing. And so if you want to get pregnant, you need the sperm thing. This is an interesting picture to me. So those are all sperm. And every single one of them looks perfect. There's not that many sperm here in this picture because you see there's millions in a sample, right? But every single one that's in this picture is normal. That's kind of unusual. It's a doctored picture, I think. I think they were only looking at normal sperm here. Other factors. So there's a lot of other things that influence getting pregnant. I use this as an example just because women with significant renal disease just have a hard time getting pregnant. We don't really necessarily understand why. And so I think that what you want to do is it's the same thing we said at the beginning. Make sure you're medically healthy. Make sure you've done everything to sort of take care of all the things you can take care of before you're getting pregnant, because those things might be a problem in pregnancy, and it's much harder to deal with anything in pregnancy than before. Typical evaluation. So if you come in and see me and say, I have infertility, I'm trying to get pregnant, these are the types of things that are going to come up. And they come up for various reasons. So almost everybody is going to get some cycle day 3 labs, in particular the FSH and the AMH. That stands for follicle-stimulating hormone and anti-Mullerian hormone. These are two hormones that do a pretty good job of helping us predict whether a woman has the potential to get pregnant. It doesn't tell you that it will work, but it can tell you when it's probably not going to work. So it's a useful tool, sort of in the negative, I guess. Sometimes you do some of those labs on day 10, and the decision for that is usually an insurance-based one. So most couples in the state of Massachusetts have coverage for infertility, and the infertility coverage dictates often what we do here. Right? So I don't usually order day 10 labs for me, but I sometimes have to order day 10 labs for the insurance. And if I don't order the day 10 labs and get them, and they want them, they will simply say no to any coverage. So you have to play the game by their rules because you want them to pay for it. So do so. But that does give us a little more information. We'll get to a little bit more of that on the next slide or two. Sonohystrography is the ultrasound-based test that I usually use to look at the tubes. It also gives me information about the uterus as a whole. Also gives me information about the pelvis and the ovaries. So it's a pretty multifactorial kind of test. More rarely, hysterosalpingography is used. That's the X-ray dye test that gave us that funky-looking uterus. That's a test that really just gives you a picture of the inside of the uterus and the tubes. So it doesn't really give you the structure of the uterus or the ovaries or the pelvis so much. Semen analysis for the male partner, and again, if no male partner is involved, we don't ask the female partner of a female to give us a sperm sample because it doesn't work. Additional thoughts. You might have to do more than the standards, so sometimes you're asked to do other things, like insurance might demand varicella or rubella titers, chickenpox and German measles. Probably everyone in this room has been vaccinated against German measles multiple times in your life. It's also in the MMR vaccine, which you probably got like 3 or 4 times when you were little, and then maybe even a couple times as an adult. And so we've probably been vaccinated against that. And probably all of us have had varicella. Probably have immunity to these things, but sometimes insurance companies will want to see that in a test. So if they demand it, that's what you do. You might do infectious disease screening, hepatitis, HIV, et cetera. And that's because these things can be important in, so for instance, let's say you were to find out you were HIV positive, you would have a very high rate, meaning about 30% rate, of transmission of HIV to a fetus if you didn't treat that. If you treated it and inhibit that, you can bring that rate down to less than 1%. And so that's a very impressive change. And since that's a pretty important disease, you'd want to know. If you're not really at risk for it, it's unlikely you're going to find it. But you might want to do some sort of screening here. Genetic screening is becoming more and more and more available, more and more cost effective, and more used. So a lot of people will do cystic fibrosis or spinal muscular atrophy testing, and maybe even more than that. In my office, we have a group that we work with that does a large number of genetic analysis if you want it. And so you could do up to 150 genetic tests in one fell swoop, and the cost of that has gone from thousands to a few hundred in cost. And so over the last 5 years or so, that's become much more readily used. Age-based testing, like Clomid challenge testing, sort of incorporates the day 3 and day 10 testing with the use of Clomid as a way to sort of assess a woman's response. And then nutrition evaluations can be demanded by insurance or maybe smart based on a weight issue. So if you walk in and you're struggling with your weight a little bit like I do, then you might want to think about nutrition issues because carrying more weight into pregnancy is not a good thing. Smoking cessation, if you've been a smoker, we've already said we want you to stop. Maybe you need some help. They may demand that you actually test for evidence of smoking and then test negative before you can go on. So some insurance companies will make you go through that process. So if you're a smoker, they might slow you down from being able to do this. So again, if you're a smoker, quit. There's lots of reasons for that. Not necessarily that makes sense. Follow-up after the evaluation leads to a discussion about what you can do. You might find things that require further evaluation in some ways that might have very little to do with your infertility. You might find something that you have to deal with in some way. Okay. And then you might have to just start dealing with the fertility questions. So you've now done your evaluation and you've come up with a set of issues and you've identified the factors involved. You've considered the medical issues, you considered the age, you considered all that other preparation stuff, and now you're ready to go ahead. Ovulation induction. So this is trying to make women grow follicles so that they can ovulate. Okay. Most women are doing that, but Some women don't do that very well, and these are things we can use to help do that in various settings. So we can use oral medications like Clomid or tamoxifen or letrozole to help a woman grow more follicles. We can use other medications to help with that kind of process, like dexamethasone, metformin, or oral contraceptives, believe it or not. I know that sounds weird to use oral contraceptives to help a woman get pregnant, but you can do that. So we use those things as we need to or seem reasonable. And injectable medications like FSH or FSH and LH combined. And these are hormones that are normally made by the pituitary gland that turn the ovaries on and make the ovaries produce follicles. And we're just going to override that by not worrying about the pituitary anymore. We'll just give it. And so this is what we use when we do things like in vitro fertilization. So those are sort of the options to help her produce ovulation. If you happen to be overweight and have PCOS and you're not ovulating well, all this stuff is not as good as weight loss. Ovulation trigger and detection. So detecting ovulation is down here, trigger is up here. So these are things we can use to make women actually ovulate. So when they're ready to ovulate, we can actually biochemically give them something to make them ovulate. And the advantage of that is now we can see when we're going to ovulate. We know when the ovulation is going to occur. And then we can try to time exposure to sperm with that. Down here, you can do this on your own. So you can do various things to try to figure out whether you're ovulating. You can do predictor kits. You can do ultrasound monitoring and see whether you have a growing follicle and start predicting when you're going to ovulate. You can do lab evaluations. You can do body temperature charting. And you can do just general cycle monitoring, all of which can help you predict ovulation. And that might help you predict when to be sexual or when not to be sexual or when to do an insemination or that sort of thing. And depending on what kind of cycle you're running, you might incorporate one or more of these things into your cycle. Exposure to sperm. Obviously, sperm isn't required. We decided that earlier, even though we might understand that men might not be completely required in the future, right? But we need to get sperm exposure, at least currently. So you can do that by timed intercourse. Obviously, you have to have a partner involved. Partner can be used loosely. I have seen literally everything you can come up with in my career, where people have used all sorts of different versions of what a partner is. You know, the bar, the people they know from in their housing complex to people they're married to whoever, right? So it depends on what you're trying to do. I sort of recommend thinking about your risk involved in that, but nonetheless, people are creative sometimes. Home insemination methods. So there are techniques that women use in their homes to use either a sperm donor or sperm from a donor or sperm they bought from a sperm bank to try to get pregnant. This is a little bit on the difficult side if you're going to try to do something like an intrauterine placement of that. It's hard to do that at home anyway, but it's also maybe not the best method because of other things. So I might recommend that you go to this one, which is timed insemination, which means you go to someone like me and you have a specimen prepped to be able to put in the uterus at the right time. Or you can do something like in vitro fertilization, which is a much more complex process by which you create follicular growth and then collect the eggs and in a lab expose to sperm and try to get fertilization to occur there. This is a more normal look for sperm. These are not all normal. So this is a real one. This isn't a doctored one. Intrauterine insemination requires that a sample is prepped before it's being placed in the uterus. I say that because in my career I've actually heard of people not prepping samples and putting them in the uterus. That's a good way to make a woman really, really uncomfortable because the uterus will contract probably titanically when you do that. So you really want this to be prepped. So I would recommend that you go to someone who does inseminations, not someone who is going to dabble in inseminations. I don't recommend trying to do that at home. I think it's hard to have a sample that's prepped appropriately to do this at home. Home insemination would really be limited to placing the sperm into the vagina or into the cervix, not into the uterus itself. Donor insemination is most typically done by a frozen sample and needs to be prepped, but the FDA has some specific guidelines for this. So if you were to buy a sample that you're going to use for a donor, you'd want to make sure you're following the FDA guidelines for this because the clinics would be expected and required to follow those guidelines. In vitro, this complex process where we hyperstimulate the ovaries, create a number of eggs, and try to collect those eggs, put them into the lab, get fertilization to occur in the lab in various ways. You can actually take individual sperm and inject them into eggs, or you can take eggs and expose them to a larger number of sperm and let them fertilize on their own. Once you get embryos, you can grow those embryos, and then you can put embryos into the uterus. Usually not a lot of them. 1, 2, maybe. Not 8, like someone in California did. And so, otherwise known as octomom. And so we would be cautious with this, but once you put the embryos into the uterus, that does not mean they're going to work, but it means they're very likely to work. And if you look at the chance of in vitro fertilization working compared to, say, natural achievement of pregnancy, so normal couple trying to get pregnant via sex versus a couple doing in vitro fertilization, this is better. So I literally, if people ask me, what's the best way for a woman to get pregnant? Doesn't matter who she is, doesn't matter whether she's trying to get pregnant, doesn't matter whether she has an infertility problem, in vitro is better than anything. It's also riskier than everything. So it's not necessarily the first choice, but it's certainly the best choice from a success point of view. Lots of injections, lots of cost, and some real risks. It's been around for about 50 years now, so we've worked out some of the kinks. The original studies for in vitro had a 4% success rate. That's not very good. The most recent published IVF rates for the country are about a 50% pregnancy rate. So we've come a long way. Now these are embryos. These are 2 different embryos looking for a home, right? They are ready for implantation. This is after the IVF process. They're ready. This is what you're trying to get to if you're doing IVF. Additional processes, we already mentioned this. This is the injection of an individual sperm into an individual egg. This is a process called hatching, which can be used to help for implantation issues for some women. You can use IVF with donor eggs for women who have age-related problems with their fertility. So this means she's not getting pregnant with her own genetic eggs, but she's getting pregnant with her partner's sperm being involved with the eggs that she used from a donor. Kind of wild, right? But it means she's giving birth to a child that is from her partner and some other woman. Right? PGD and PGS are methods of looking at genetics for embryos, and then you can use that to avoid genetic disorders. So if you've tested positive for cystic fibrosis and your partner tested positive for cystic fibrosis, both in the carrier status, you could look for those mutations in a fetus, or not a fetus, in an embryo. And if that embryo showed that, you could choose not to use that embryo. So you could literally avoid diseases. Pretty powerful stuff. I recently had a woman who had a family history of Huntington's chorea. Huntington's is a pretty brutal disease that kills people usually in their 50s. And it's an autosomal dominant disease. So if you have a mutation for Huntington's, you have the disease. And she was starting to do infertility care, and she decided that she wanted to do testing for Huntington's because her mother had Huntington's, which means she's got a 50% chance of having Huntington's. She has Huntington's. That means that now she gets to do 2 things that are very, one thing that I'm not so sure is a good thing, but one thing is that she knows she's got Huntington's. She's going to have the disease. Second, she now can do genetic analysis and avoid her child from having Huntington's. She can end it. She can stop it from being passed on. And that's exactly what she's doing. So she's going to have a child probably. She's going through the process. And she's going to avoid Huntington's for her child, even though her child would have a 50% risk. That's a pretty powerful statement. Okay. Cryopreservation of embryos can be done. Cryopreservation of eggs is a new burgeoning area where we can potentially take women who aren't trying to get pregnant right now, get eggs from them, and keep them for the future, and then try to use them in the future to create embryos. Cryopreservation of sperm is a long-time thing. That's been going on for a while. That's another embryo waiting to go, another nice 4-cell embryo, beautiful-looking embryo, just waiting for a home. Luteal support. When we do many of the things we do for reproduction, we use a luteal phase support with estrogen and sometimes progesterone. I should say it the other way, progesterone, sometimes estrogen. And when we do things like IVF, we always use it. But with multiple losses, we often use it, and sometimes outside of IVF for different forms of implantation failure, we might use it. So this is another additional support that we might use. Consequences. These are the risks. I think you figured out what I've emphasized. Multiple pregnancy. The rate of multiple pregnancy in the United States is now dropping again because we've gotten more conservative with our treatment within the IVF world. But for about 20 years before the last 5, we had a steady increase in the rate of multiple pregnancy in this country, and it was related mainly to in vitro fertilization and the results of it. So multiple pregnancy with any fertility treatment is real. Right? Every treatment that I just described to you, essentially every treatment, has an increased rate of multiple pregnancy. That's something you definitely need to think about. Hyperstimulation syndrome is hard to explain in a sentence or two, but it can be a serious problem, and in rare forms can be life-threatening, and is seen with the more intense treatments. Idiosyncratic side effects, like for instance, Clomid will make women feel like they're a little bit menopausal while they're taking the medication. So hot flashes, night sweats, vaginal dryness, common effect. Not usually enough to stop them from using it, but it's something that they notice. Moodiness and emotionality come with the fluctuation of the hormones that we see as a result of what we give. Headaches can go with that as well. And then there's a whole mile-long list of all sorts of other things that have been listed that don't happen very commonly. And so you really have to think about what you're doing, because the more aggressive the therapy, the more likely you are to see the side effects. So you don't just necessarily say, okay, I've got a little infertility, I'm going to do IVF, because this maximizes that. Cost. These things are expensive. Depends on where you are in the country, but you can spend tens of thousands of dollars, or ten of thousands of dollars. Is that how you say that? So you can spend easily $10,000 on a single cycle of treatment, depending on what you're doing. You can also spend a lot less than that, depending on what you pick and what's reasonable for you. So it's important to go through this process and try to figure out what we can do. Certainly in Massachusetts, we're fortunate that infertility, we're in what we call a mandated state. The state has mandated that insurance carriers cover infertility, but there are some restrictions within that, or limitations within that. So not all coverages in Massachusetts actually do this, because there are some loopholes. The interesting one, I don't understand why this would be the way the state does it, but the state-based insurances don't follow that rule. So the state mandates that the insurers that are private have to do this, but their own insurances, they don't do it. Monitoring. There's a lot of different ways to monitor things, but typically you're doing some of these things in a cycle. You're going to be doing ultrasound monitoring or lab evaluations, or sometimes both, and sometimes closely monitoring pregnancy once it is obtained. So you would look, the patients I help get pregnant, I'm usually seeing them 2 or 3 times before they would normally see their OB. I'm doing testing and doing ultrasound and verifying that they have one baby, and it's in the right place, and it's growing well. And so the process of dealing with infertility also comes with this additional level of monitoring. And that's what you're trying to get to, babies. Lots of them. Maybe not all at once, maybe not all for you, but maybe share that for the whole village, right? But that's what we're trying to get to. And it's we're fortunate in that in this field, one of the reasons why I went into it was because it works. We're successful. We are commonly going to get to the result we want. It doesn't always work, but it works for a lot of people. Okay. Thank you very much.